everybody to session 6 of the Oxygen Therapy and Critical Care course, the case-based series. Today's topic is basic ICU care considerations. As usual, we are here with Professor Rwanda-Banguti, Liberata, Dr. Honorine, Dr. Jackson, and Dr. Francois. And the housekeeping rules for today are the same as usual. If you would like to participate in the discussion, please use the chat box. If you have any IT issues, send a message through the chat. And the session is being recorded, and your attendance is consent to be recorded. If you can't hear the audio, you won't be able to hear me right now, but the instructions are on the screen. So these are tips that you can use to help if your audio breaks out at any point during the presentation. And with that, I'll pass it on to Professor Banguti.
Thank you very much, Alana. Thank you very much, lovely team of colleagues, and thank you very much to the audience. So today we are continuing our session. The session number 6 is one of the most interesting. I could hear some comment of the audience when I shared the poster. Oh, this is what I was waiting for, because we are talking about basic of ICU care considerations. So we've been waiting for this for long. Many times we've talked about critical care, intensive care, many things. So today we have 1 hour enough to go in deep of the intensive care to understand. Can we share the next slide, please? So to understand, are you seeing my screen? Can you see my PowerPoint?
No, not yet.
Oh, I have to share. Something is wrong. Okay, let me share. Can you see it now?
Yes.
Okay, so as we are saying, the topic will be divided into 2 to 4 different topics. One will be the bare minimum to set up an ICU. Many people, when they talk about ICU, they think about very fancy machine, very fancy equipment, very highly specialized or sub-specialized stuff, and very fancy equipment. But today we shall discuss a little bit about the bare minimum to start an ICU, and what is the needed monitoring, and what do we monitor in ICU? Which kind of staff are we working with? Admission. So who is supposed to be admitted in ICU? How is the stay in ICU? And when do we discharge from ICU? And we'll have to discuss about a few bundles of the critical care. So then there will be 4 different breakout sessions for trying to dig in depth of those topics. So by the end of the session, we're expecting to change our understanding practice in terms of the minimum standard for ICU, and so that everyone can understand that even with the minimum standard, if this minimum equipment I have, I can start a small ICU. Also, to identify the key healthcare providers we need in ICU. Sometimes in a hospital, they tell you, oh, you will be working in ICU. So you need to understand why me and what can I do in ICU. To discuss the type of monitor needed in intensive care. List the specialized equipment needed in intensive care unit. What are the specialized units? What makes the intensive care unit different from the ward? To list the most common indications for ICU admission, to understand and prevent the most common complications that occur in the ICU stay, during the ICU stay, and review or develop and implement ICU care bundles for your ICU procedure and protocols. So from this, let us pass the floor to Xavier. Xavier will take us through. Yes.
Thank you, Prof, for the introduction. And good afternoon, the audience. So as we are introducing the basic of ICU, here we are having a case, which is in somewhere in his facility, a 46-year-old male presented with hypoxemia, and severe respiratory distress, whom has been tested SARS-CoV-2 positive on diabetes and obese. But our hospital these days, Nyarugenge Referral Center, is very busy and beds. So as a healthcare provider on this patient, what can you do locally while we are waiting the bed to be available?
I can't see Francois. Alana, can you share with us the short video? Alana?
Yes, yeah.
So as Francois is coming back, we can start with that video to give you an overview of one of the intensive care units in Rwanda.
Right. I was asking Dr. Francois separately if he could give me permissions, because I have the email, but not the permission to open the video.
So he has disappeared. So if we can't get him,
yeah,
let us just continue. Francois, are you back? Seems like Francois disappeared with his video.
Yeah, I think his bandwidth, he dropped off the call.
So the video was a video taken from Nyarugenge this hospital, which is one of our intensive care units where we are hospitalizing COVID. COVID is back again. So COVID is back again, and we were showing you through the video how is the setup in Nyarugenge, so that we could understand. Xavier, just let me know when you are ready to continue. I'm standing for you. So there you could understand what's the definition of ICU and identify the minimum standards of an ICU and the people in that unit. So this is from Europe, not from those. We had one from Rwanda, which we can't play for now. But this is, you can see how it is in Europe, in some other places. So we can see this environment, which we call ICU. For those who are familiar with an hospital setting, Francois, are you back?
Yes, I'm back.
So I think Alana needed your permission to open the video, but because if you are running late, you can just take over from here and continue. But if you can give her permission, she can open for you, and you can see it at the end.
We'll play the end. I apologize for this disruption. I'm on my duty. I've been called and I'm using the phone, so there from calls. But we can continue as you say. What is an ICU? Actually, an ICU is a place where we have to focus on things like managing patients with life-threatening condition, and also having a continuing of these patients. Managing such patients require specifically and specialized equipment and staff. So this unit has to be specific for the patient care as we are managing people with multiple organ dysfunction. Next, please. Next. So this is what I was trying to explain. And when we see the minimum standard to set up an ICU is not many requirements. Just you need to understand that your ICU must have a continuous monitoring. That is one as a component. Second, you must have trained healthcare providers, not just saying, I have equipment so that I have an ICU without trained staff to use it. We used to use a joke like having a car without a driving license is also another issue. Also, we must have a system to deliver that critical care. So if the system is not functioning also, your ICU must fail and not deliver the care it should give. I think our specialized patient care equipment, Prof in introduction used to say not funny equipment, but just equipment which may help you to do this continuous monitoring and provide the care in managing such patients as we saw in the definition of ICU. The other thing, it's the link between ICU and other departments where you will be needing like theater, imaging, and the laboratory. Those links also for rapid access have to be some of the components when you want to set up your ICU in the facility where you are to manage the case we have. So how will you then make your ICU better and good? The physical space is needed because we need enough space in between different beds so that movement on the placement of different equipment can be promising or allowing people to walk around and monitoring the patient. Other thing is monitoring technology and support, but also without forgetting that having human resource. Human resource also is critical because ICU managing this life-threatening patients, you must have enough human resources to support. Another thing is critical care services provided. We will see in next slides patients who are admitted, bundles of patients admitted, where you have to know when to admit and when not to admit. So that this will be ended up by having a quality improvement project on your set up ICU in the health facility where you are. Next. Generic requirements. ICU is not complicated as people may think. Just think about the component I'm coming to describe above and think about staffing you will need. Operation. Operation meaning protocols in ICU, protocols in ICU, administrative team to help to support the well functioning of your critical care when it's set down nearby is connected with other needed departments like theater or laboratory departments. And then you may need equipment for critical care and also ability for intensive monitoring at the bedside. So if you meet the above things, you cannot fear to set up an ICU in the place where you are. Regarding the staffing, as I say, the key healthcare providers, this is our staff at my hospital, Alganga District Hospital, who are working in the COVID center ICU unit. So this needs a timely immobilization of the ICU team and the supporting service. What is mean? Timely mobilization ICU team in COVID cases, we have to be always ready to intervene and being in the unit always, so that anytime any change of this ref threatening, we can intervene. So the support services also helps us to be always in a good condition and intervene on right time for the patient when needed. Next, please. Next, please. So apart the staff, apart the supporting services, also come back. Yeah, to practice good ICU and provide necessary care needed, we need this common equipment. There is a list which I think we'll discuss in details in our breakout session one by one, so that our ICU can be set up and then being function. Next. Next. Yeah, I said we discuss in breakout session one by one. We can go to the, yes. So from my presentation for the bare minimum to set up an ICU, don't think there is an absolute concept to have an ICU, my ICU at Nyarugenge. Yeah, there is minimum settings, but it's not always the same all over the world. The important is to have the concept of having an ICU and its roles and the staff. So this also is relative to the reality of the particular healthcare. Reason why, to the case presented above, don't fear to set up an area where you can monitor that patient while we are waiting the Nyarugenge hospital to have an available bed. Just let me repeat, Rodrigo. Critical care is a moment in time, so we don't have to lose the time, and is the delivery of care that is time critical. When you call Nyarugenge, there is no bed, please don't say, I'm giving up because there is no bed at Nyarugenge. And think about if your patient has a critical of admission in ICU when you think. So we will discuss this in next slides by my colleagues. Can Liberata take over and explain the monitoring staff has to do?
Thank you so much, Dr. Xavier. My talk is about monitoring of ICU patients. As from your presentation, the continuous monitoring was the first point among the standards component of setting up an ICU. Next slide. So if you go to different literatures, you find that 80% of patients displays some alert sign before having cardiac arrest. So if you have competent healthcare providers in ICU who can do continuous monitoring on a different functions like oxygenation, ventilation, circulation, and temperature, we can save many patients and avoid those cardiac arrest. So if we go to oxygenation, what do we monitor? If we are to monitor the oxygenation of our ICU patients, if we check the color of the skin or the color of the mucous membranes, we can find out that something is wrong and do quick interventions, depends on the condition of our patients. So what do we need to use? We need to use the pulse oximeter to check the level of oxygenation of our patients. And we can also set some limits on our monitors. If we have cardiac monitor, as you see on our shared screen, if you have a cardiac monitor, we can set in the alarms so that even if you can be far, but the alarms will be ringing, telling you that there is a low oxygen, the SpO2 is going down. For ventilation, we need to check breath sounds through our lung auscultations. And on the ventilator, we can also check the ventilation of our patients by and the cardiac monitor, we can use capnography and check the level of CO2 to see if our patient is not going into acidosis or alkalosis. So for equipment, if we have like on a cardiac monitor, we set the alarms which will be linking if there is any disconnection. Either the tubing is disconnected from the patient or those capnography tubing, the cables are disconnected. All those things will be linking to tell us that there is something wrong for which is like interrupting our continuous monitoring for ventilation of our patient. So for saturation, we need to use like, it's like our culture for checking the pulse rate by palpating on different areas to check the pulse of our patients. We can auscultate to see if the heart sounds are normal or abnormal. We have monitor like an ECG machine, or the cardiac monitor can show us the ECG and tell us, and if we have good healthcare providers who can interpret well the ECG, the blood pressure, how much is it, the heart rate, how much is it low or high? So those ECGs, the BP curve, we can use invasive blood pressure or non-invasive, depends on how our patient is critically sick. Then the pulse oximeter can show us the heart rate of our patients. So for the temperature, simply by touching the skin of our patients, if we are doing like assessment, for simply touching the skin of our patients, we can feel like this patient is hot or cold. Or for equipment, we can use the temperature probe, which is also connected to the cardiac monitor, and we keep it on our patients so that it will continuously tell us how much the body temperature the patient is having. Of course, from the cardiac monitor, we can set low temperature alarms or high temperature alarms so that whenever the body temperature of our patient rises or rolls, the cardiac monitor, the alarms will be linking. Next slide, please. So on vital signs, again, we are back on the blood pressure, which can be low or high, and this may be caused by different causes. If we have an hypertensive patient in ICU, we need to think about the decreased intravascular volume, which happens most of the time. We need to think about the high PEEP. We know with our settings, we set the PEEP, which is a positive end expiratory pressure for our patients, we set it on a vent. So if it is high, it can have a negative impact and lead to the decrease of blood pressure of our patients. Maybe the patient is having cardiac failure, or the patient has received the sedative drugs, which can have an impact on blood pressure. Maybe we'll have a detailed discussion in the breakout sessions about those drugs. Maybe there is a leakage from drainage system. Remember, an ICU patient is someone critically sick. He might have some drainage from chest tubes, or from like we are draining like those intracranial hemorrhage. So those leakage, if they are high, they can lead to low blood pressure, or maybe IV sites has disconnected. It may happen. So the lines can be disconnected from their sites and cause the bleeding, which will finally lead to low blood pressure. So this is a reminder that a low blood pressure, it's a late sign of decreased cardiac output. So we don't rely on the low blood pressure to decide if a patient is having decreased cardiac output. The early sign will be discussed in the breakout session. The patients can have hypertension. due to different causes, of course. Maybe the patient is not well sedated, or some drugs like vasopressors. If we have given vasopressors to increase the blood pressure of our patient, sometimes they can lead to high blood pressure if they are not well monitored. Next slide. So the heart rate, which is a very good vital for our patients, if you are closely monitoring your patient and you find that either the heart rate is decreasing or increasing, or there is like abnormal readings from the ECG. So those are the things which should be immediately taken attention and work to help the patients. Some possible causes for those, the disturbances on heart rate, maybe the patient might not be well sedated. Some drugs can low or increase the heart rate. If there is a decreased PaO2, they will be like using compensatory mechanism to increase the oxygenation by increasing the heart rate. If there is a decreased PaCO2 or increased PaCO2, all of those ones also will disturb the heart rate of our patients. Next slide, please. Next slide. So on temperature, as we've seen it, on skin, when you are assessing, you can just feel like this patient is cold or hot. So hypothermia can be caused by decrease of environmental temperature, or some patient is having an infection. For hypothermia, if there is an increased metabolic rate, this also can lead for high body temperature, or if the patient is struggling with ventilator. Remember, most of our patients are on a ventilator machine. If there is a ventilator asynchrony, means the patient is not tolerating like ventilator settings, this will increase the metabolic rate and lead to hyperthermia. Also infection, again, it's obvious to increase the body temperature. Next slide, please. Other vitals, those we have to follow, includes respiratory rate, which should be monitored closely, and we know that it can be altered by ventilator settings. If the patient is not tolerating well the ventilator settings, there will be like a compensatory mechanism by fighting with those settings, and it lead to increase of respiratory rate. If there is a change in metabolic needs, we've seen it in the previous slides. If there is a decrease in PaO2, all will be like the patient is trying to compensate. If there is a successfully weaning, you know, the patient comes in the ICU, but he will never be on the machine forever. We try to wean the patient from the machine, and whenever we change the setting, the patient may be like he's not tolerating well and leads to tachypnea. Capillary refill time, it's also another vital to check, because it will always show us that our patient is well perfused or not. We will discuss this in detail in the breakout sessions. And tidal CO2, which would tell us if our patient is getting to acidosis or alkalosis. Then continuous SpO2 monitoring. The probe should be always on our patients to continuously monitor the oxygenation of our patients. Central venous pressure, we use it as an invasive blood pressure monitoring if the non-invasive is not working for our patients. Another key point to monitor is the urine output for our patient. We have the normal urine output and for adults and for kids. So whenever the urine output is decreased or increased, this is why we always monitor the output and input. Please report this or take an action as quick as you can. We should monitor it hourly. We don't wait for 24 hours to report that there is a decrease of urine for our patient. Next slide, please. For physical examination with continuous monitoring, we need to closely monitor the endotracheal tube of our patients. Sometimes there is a leakage around, air leakage around the ET tube, which might show you that maybe the cuff pressure, maybe From Xavier, we show you the endotracheal tube, how it is, and the cuff pressure that we are saying here, it's what will help us to protect the airways of our patients. If the ruptures deflate, it may cause the leak around the ETT tube. So this is, we healthcare providers who are working in intensive care should always look at, so that we can detect as early as possible and help the patients. Airway secretions, when we are suctioning our patients, we have to observe the color and the viscosity of the secretions that we are bringing out. Breath sound, whenever we are monitoring, we have to auscultate and make sure that we really understand the breath sound of these patients. They might be there or not, it depends on the patient's condition. Subcutaneous emphysema, we need to palpate and feel the chest of our patients and see if there is no this emphysema in case of like a patient has had a fresh tracheostomy, or those who have tension in pneumothorax, we can feel it by palpating our patients. If there is an air leak via chest tube, it may suggest again that someone is having an pneumothorax, or there is a fistula between the bronchi and the pleural. Sometimes our patients in ICU can have gastric distension. If there is a displacement of an endotracheal tube, sometimes this is why each morning when you are assessing a patient, we have to label, we have to mention where the position of endotracheal tube on the lips, at the level of the lips, so that when it comes out, people will be knowing that this tube was not here before. There is something wrong. This displacement can lead to air swallowing and lead to gastric distension, of course. If there is a nutritional intolerance, you are feeding a patient, he is not tolerating, the abdomen will be distended. Next, please. The behavior of our patients. If you have a patient in the ICU, you will find that the behaviors start to change. Maybe the patient is anxious or has fear for different reasons. The patient can't sleep well. The patient is agitated. Maybe he's hypoxic, or maybe there is a decrease in GCS. If there is a decrease in perfusion, especially for the brain, the patient will start like the GCS will be decreasing, and the patient will be changing the behavior. He will not behave as you have known the patient in the previous hours. If there is rising in the PSO2, you see the patient is getting into acidosis, so the patient will be like, he can't sleep, he's not well. Drugs effects depends on the drugs that the patient is taking. Maybe some are disturbing. You remember, some can disturb the heart rate of the patient or the blood pressure of the patient. So we always need to do continuous monitoring by checking the drug chart of our patient to know really what is behind the change of behavior to our patient. Next slide. We can't forget lab investigations, as they will be telling us what issue the patient is having. Arterial blood gas, maybe we'll have a discuss on it in the breakout sessions. Whenever there is a change on ventilator settings, we need to check the ABG. Or if there is any unexplained change in the patient's conditions, there is also, it's good also to check the ABG of these patients. Electrolytes, you know them well. Those ones can, if they are not recognized early, they can lead to life-threatening condition or cause deterioration of our patients. Urea and creatinine also should be monitored twice or weekly. So most of our patients, if they are not well monitored, they end up with kidney injury, which is not good. Liver functions, because of, like, if I can call it polypharmacy of ICU patient, we need to test the liver function and minimize the risk for it to be damaged. X-ray, for close monitoring, we need to do X-rays and see if there is no new condition for our patients. And we can do cultures for various sites. You remember, our patients in the ICU is having multiple lines. So it's good to do cultures and see if they're not getting any infection. So thank you so much. I think next talk is for Dr. Honorine.
Thank you very much, Liberata. I'm going to talk about ICU admission, indication of ICU admission, and what will happen during ICU stay, and when we decide to discharge a patient from ICU. Can someone share or what can be any indication of admitting a patient in ICU? I'm waiting for your answers.
Please feel free to share in the chat admission for ICU admission, indication for ICU admission.
Thanks, Prof. Respiratory support through low GCS through patient with respiratory failure, chest trauma through So we can go on the next slide, then we can see all together the indications. So there are many indications for ICU admissions, but we are going to go through on most of them. The first one is the one with the threatened airways. It means a patient with airways obstruction like edemas or from infection like for any kidney epiglottitis to open the airways. The other one is oral respiratory arrest. Any patient who can't breathe should be in the ICU for respiratory support. Any patient with a tachypnea with a respiratory rate greater than 40 or bradypnea with a respiratory rate less than 8 breaths per minute. This one may be changed depending on age, like in children will be different from the adult one. Every patient who is in severe respiratory distress or bradypnea needs mechanical vent support in the ICU. Patients who are hypoxic with a saturation less than 90% on a high flow of greater than 50% of oxygen. All patients who had cardiac arrest and recovered with the cardiac circulation should be admitted in ICU. A patient with a pulse rate less than 40 beats per minute or greater than 140 per minute should be admitted in ICU for close monitoring or circulatory support. Here it included with patients with some cardiac arrhythmia that need close monitoring or support in the ICU. Patient with shock with the hypotension that may be due to many things. It may be sepsis, it may be hemorrhagic, it may be obstructive, or it may be neurogenic. All of those ones should be admitted in the ICU. Other patients who had a sudden decreased level of consciousness that will be like a drop of greater than 2 points from 15. This patient would be closed to be in ICU or one with GCS Glasgow Coma scale that is less than 80 over 15. This one should be intubated and admitted in the ICU. The patient with repeat or prolonged seizures should be in IC to protect airways and for preventing aspiration during seizures, or patient with an increased carbon dioxide that lead in respiratory acidosis should be in the ICU for respiratory support. Next slide. So we can go to the first one, then I can ask a question. So the one before.
Your Honor, Reen, someone has raised.
Is Dr. Josue. Yeah, we can hear from him. Hello,
Dr.
Dr. Josue.
Josue, do you have a question? I think it's just a mismanipulation.
Okay.
Okay. I want to hear from audience, or you saw the ICU is a very interesting area. So you see patients have to be monitored to have so many cares. Who can tell us most complication patient in the ICU can meet from there? Try to answer through the chat so I can see your answer.
So the question is, what are the probable complications over the course of an ICU management?
Okay, thank you. It's true. Tracheal stenosis, true. Sepsis, infections, true. Infections, bed sores, true. True, DVT, pressure ulcers, bed sores, yeah. Okay, can go to the next slide. We can go through the most complication of stay in ICU. Thanks for the audience. Most of you have answered the complications. There are many, but we are going to talk about, turn out the most one. The VAP is a ventilation-associated pneumonia. I saw someone answered about it. This is the one of most complication where the patient gets pneumonia due to be on a mechanical vent. We have to know how to prevent it. We have to know if really there is no much leak around the trachea tube. The patient has to be on between 30 to 40 on the bed, and always we have to suck the trachea and the trachea tube for the patient who are on bed on mechanical vent. The other one is the catheter-associated urinary tract infection. This one is included also in infection. We have to know how to put a Foley catheter with septic conditions, and we have to know when to change the Foley catheter. It depends on the setting. Most of the time it is around 14 days where we have to change it. So, and we have to look out when we are changing position of the patient to see any discharge around the Foley catheter and the color of the urine that is coming from the bladder of the patient. Another one, those medication errors. So in ICU, the patient may be on different medications. We have to pay attention on different ampoules we use to prevent the errors in medication. For example, like in our setting, we have an ampoule of adrenaline that with the same color of the one of dexamethasone. You can give adrenaline thinking is the dexamethasone, and the patient may have a cardiac arrest due that adrenaline. So we have to be vigilant on which medication we are going to give. So you have seen the patient may have in some equipment we use in ICU. Also, we use the central lines. Central lines may lead to central line associated bloodstream infection. We have to know how to use them septically. We have to know when to change them. We have to check always if there's any discharge around the central line insertion, and also we have to check when we aspirate if it's coming a clear blood, or if any discharge that is coming from the central line. And you know, our patient in the ICU, some of them, depending on the clinical status, have to be on sedation. Sometimes they can be over sedated and take a long time stay in the ICU. So we have to know for not over sedate our patient in the ICU. And some patients may develop what we call delirium. Delirium is like a mental disability that is showed with a confusion in space, in time, and may be also is associated with agitations. There are many factors that lead to delirium. It may due to the chronic disease or different medication we give in ICU, or infections, surgery. So different factors may lead to delirium for a patient in the ICUs. Patient may have the deep venous thrombosis of pulmonary embolism due to be bedridden in the ICU. So this is why our patient with no contraindication should be on DVT prophylaxis. For patients in ICU, they usually develop malnutrition depending on the conditions they have, like a patient who underwent internal surgery or what that preventing them to eat properly, they develop malnutrition. Or patient in the ICU, most of the time they develop feeding intolerance due to paralytic areas, due to be not being in movement, all kind of things that lead to improper eating, lead to malnutrition for patients in the ICU. Also, they develop most of the time the stress ulcers. Most of the patients in the ICU, because of stress of ICU, they develop stress ulcers, but they have to be under prophylaxis. We used to use the proton pump inhibitors. The main person who has that risk of having stress ulcers, they are the patient with traumatic brain injury, and the patient who underwent the major surgery, or post-traumatic patient. Also, the patient may have developed antibiotic resistance. This is another complication due to many acquired infection in ICU. The other one complication is called post-ICU syndrome. This is the what we call it's a combination of different different abnormal post being in ICU, the patient develop muscle weakness, they get confused, always they need, they may have anxiety, depressions. So this what it comes after being discharged from ICU. We will talk more about post-ICU syndrome in the discussion. And also patient may have organ dysfunction due to depending on the condition the patient has. So we can go to the next slide. So the patient may be may after staying in ICU, he or she underwent treatment depending on the disease, but there is a time to be discharged from ICU. Like if we do not need an ICU monitoring or care, the ward where they do regular monitoring. Another thing, when the patient has deteriorated with irreversible physiological status, and we do not need any active intervention, with this patient, there is a talk. We should have a team of doctors working in ICU and the family. They have to talk about withdrawal therapy, and here we have to educate the family that we will not need the active intervention, then of treatment, so we can decide to withdraw therapy. This have to be to have an education of the family, that then you make sure the family knows what we are going to do on his or her patients. I think it's finished. We were going to band of care in ICU Jackson. We're going to talk about it. Thank you, the audience.
Thank you too.
Hello guys, and thank you for joining this conversation and just knowledge sharing. I'm happy that I will be talking to nurses who are working in ICU out there, and I can't start this presentation without thanking them, because they are doing a great job with this concept of bundles of care in ICU. So next slide. So what is a bundle or a bundle of care? It's a group of evidence-based interventions that are carried in ICU. They are carried together so that they may result in a better outcome, that rather than if they are implemented individually. So those bundles are usually 3 to 4, which are divided into small chunks, and those chunks are being very simple, so that someone cannot just forget to take them into consideration when giving care to the patient. So as I said, there should be evidence-based, so which were tested via research, and they showed good outcome. So at the end of the day, you need that to put them into practice so that all the interventions are consistent for all patients at all times, so that improve care of the patient. Next slide. So as I said, should be thanking the nurses who are working in ICU out there, or people who are providing some of the band of care in ICU. We have some examples here. They are like ventilator-associated pneumonia. And as Dr. Honorin discussed, all the complications that we have in ICU, the studies or the reviews showed some bundles that we need to apply so that we overcome all the complications that the patient may have when once in ICU or after long stay in ICU. So you can see that you have a VAP or ventilator-associated pneumonia prevention bundle. As I discussed, you can see that they reduce mortality, they reduce ventilation days, they reduce, and they show when you comply with it, it shows good outcome. Central bundle, they are severe sepsis bundles. We have urinary catheter insertion bundles. The CVC care bundle, which is the first bundle which was introduced by Dr. Pronovost. This is a doctor who started the first bundle in ICU, and he was just preventing infection post insertion of the central venous catheter. They are the current and commonest used bundle, which is the WHO surgery safety checklist, which shows that there is 36% reduction in cost of complications. So these are all types of care bundles in ICU that we can offer to our patient and get good outcomes. We have like ICU liberation bundle that I didn't just write it down. We have other bundles like the pressure sores. They are bundles that we can apply in every condition that we need to tackle the complications that happens in ICU. Next slide. So as you can see on the slides, we have the Honorin went through all these bundles just briefly, but as you can see, we have like 5 points or 4 points for every bundle. But concerning the ventilator-associated pneumonia bundle, you need to tackle the DVT prophylaxis by providing medications or manage it conservatively by using the intermittent pneumatic compressions. You may use GIT prophylaxis by giving some PPI drugs, or you may have to elevate the head of the bed up to 30 to 45 degrees. You need to do sedation evacuation daily. You may need to do spontaneous breathing trial every day so that your patient may just be prevented from pneumonia from the normal flora from the oral cavity. So as you can see, you can have a central line in place, or most of our patients we have in our ICUs needs central lines. So to insert it or remove it needs a band of care that you need to apply. You need hand hygiene, and then maximum bioapplication upon insertion. You need a 3% chlorhexidine skin preparation, optimal catheter site, avoidance of the femoral venous associated with high prevalence of infections. You need a daily review of the line necessity. Is it needed or not? Can we remove it? Is the patient still needing a central line? Do we need it for just blood gases? We need it for just studies or just drug administration, so that you optimize the days of the central line in place. And then prompt removal of unnecessary lines is very important so that you maximize the way you can prevent blood-borne infection due to the central lines. Next. So as you can see, all our patients, we have, once they are mentally altered, they are sedated, or they need monitoring to their pressure. They need hemodynamic blood pressure monitoring. They need urinary system monitoring, or they need something that needs to assess. So sometimes you need to put a Foley catheter in place, and these are the bundles that you need to put in place. Catheter removal in case a septic condition, in case you are going to insert or remove, use regular assessment at every care. I said that the nurses are very good to doing this deal, and then training for catheter care. So train the people around you, train nurses, train all the people who are in ICU, so that they can know how to care the catheter and prevent infection, which are born with ingrained Foley catheters. And then always, as you are monitoring in and output, you also need to see if there is incontinence in the case, and just plan the care ahead. Next slide. To conclude on these types of bundle of care in ICU, remember the care bundle is a simple tool used to improve reliability in care delivery. So it's like a checklist that you need to apply to every care you are giving to a critical ill patient, so that you do not forget one chunk of the, or one element of the bundle. So these elements, as we said, they must be evidence-based, showing proof that they improved care in our settings. So at the end, this bundle of care can be used for different conditions or treatments and adapted locally to every setting that we are in during our ICU. Thank you so much. And I think Prof can begin his audience.
So as discussed, now we've taken like more than an hour for presentation. I think the next step will be a breakout session. And in a breakout session, we would like people to be more, to make it more interactive. So you can ask your question easily and get answers. Please present us in the breakout session. Give time to the audience to ask questions, so people can understand better what they've been swallowing from you in the presentation, and get time to digest and take some nutrient from it. So let us go in breakout session. Alana can break the session. So it will be short, maybe 5 to 7 minutes per session. Then we rotate until we finish the 4 and come back for the wrap up.
Great, thank you, Professor. One note to the co-panelists is that we, at 5 minutes, I'll send out a message to start preparing to move to the next breakout room. And when you get to that point, just move to the next. So if you're currently in group A, move to B. If you're in B, move to C. C, move to D, and so on. So you're always moving one letter up. If you're in group D, you move to A, and then so on like that. And then we will be around to help you if you're having trouble with that. Yeah, and so with that, you'll be moved into the breakout rooms in just a moment.
Wrap up session.
Thank you. Thank you.
So welcome back to this wrap up session.
Thank you.
So what I would like to have some of your comments. What do you feel? How was the breakout session? You can write or say something.
Was
Someone
very
say,
interesting.
someone say amazing. Any inconvenience during the breakout session? It was good. Time was short. Oh, no inconvenience at all. So we had full of knowledge as always. Oh, thank you very much. So we had some internet issues, connectivity issues. This is a shared and common complication or problem issue we have, all of us, especially in the low-income countries. But we are trying. I think in Rwanda, we are trying to make it well fixed so people can learn, because that is the way to go. We are already in the era of electronic learning. So we've discussed in some session about definition of an ICU and the equipment needed for, says as a bare minimum of ICU. Another session about monitoring, needed monitoring in ICU. So monitoring is the word you need to keep in your life. You need to monitor your life, monitor all your projects, and an ICU patient is a new project, need to be monitored from whatever input you are pushing in. You have all the organs must be monitored minute by minute, time, every hour and every day, to know where it is changing for the good or for the worse, to fix the issue. Another thing is what are the staff and faculty needed for the work. All the essential staff are needed, starting by the nurses. You know, ICU, intensive care, is equal to nursing intensive care. It started from nursing, then the doctors are like just consultants. So we need more of the nurses than others. Doctors, we can have one for 2 intensive care, but having one nurse for more than 2 patients is already a problem. So we need more nurses for good intensive care. So also another thing we discussed was about the complications. The ICU course is full of events, full of good intention, but you can also cause complications. Make sure you prevent and you are safe. Lastly, we discussed about the bundles, and I think we benefited a lot. If we can make our checklist, we learn many things, and maybe we achieve all our expected outcome. So from this point, I know the time was short. The video was recorded. We'll share again with you. Feel free in our group to ask more questions. We thank you all for being with us for the past 2 hours. Thank you very much. The session is closed. Alana, anything you want to say?
No, just thank you, and please save the date for our next session, session 7 on July 21st. We'll be talking about defining ARDS. And just a note that we'd like to thank our panelists, Professor Banguti, of course, for organizing this, and our funders at Project ECHO for making this possible. If you have any questions, please email echo@assistinternational.org, or many of you have my contact on WhatsApp. You can always reach out to me there as well. Thank you.
Thank you. Bye-bye.
Thank you very much.
Bye-bye.
Bye-bye.